name is Steinemann. I would like to introduce my experimental study that has been performed at the section of minimally invasive surgery of the University of Heidelberg in close cooperation with my co-workers Dr. Philipp Müller, Professor Beat Müller, Dr. Andreas Zerz and Professor Georg. The title of the study is Laparoscopic transgastric circumferential stapler-assisted versus endoscopic esophageal mucosectomy for Barrett's esophagus in a porcine model. In patients with large or even circumferential Barrett's esophagus, there is a relevant risk for dysplasia and early adenocarcinoma. In case of high-grade dysplasia, resection of the lesion is indicated. However, if endoscopic mucosa resection is performed extensively, there is a high risk of post-intervention stenosis. Due to piecemeal technique, there is a risk of incomplete resection and the specimen cannot be oriented for assessment of the resection margins. Furthermore, gastroesophageal reflux, as the underlying disease of Barrett's esophagus, is not treated by endoscopic mucosa resection. The aim of this study in a porcine model was therefore to develop a transgastric stapler-assisted mucosectomy, providing a circumferential en bloc specimen, avoiding postoperative stenosis, and representing an alternative for a minority of patients not amenable to endoscopic treatment. The novel technique was compared to the current gold standard EMR in a survival experiment. In the first series, the feasibility of the novel technique was demonstrated in 8 peaks, revealing an intact circumferential mucosectomy. We could show that with stapler-assisted resection, the resection could well be performed and limited to the mucosa. In a second series of experiments, stapler-assisted mucosectomy was compared to circumferential endoscopic mucosa resection in each 6 peaks during a 6 weeks survival experiment, whereas 2 peaks in the endoscopic group developed the symptomatic esophageal stenosis. No stenosis occurred in stapler-assisted mucosectomy, while in stapler-assisted mucosectomy no relevant narrowing of the esophageal lumen occurred during the 6 weeks. In all endoscopic mucosectomy resection animals, a significant narrowing was found. This despite a larger resection area in stapler-assisted versus endoscopic mucosectomy. The extent of resection by stapler-assisted mucosectomy is currently limited by the capacity of the circular stapler to contain tissue. The used circular staplers are designed to fashion anastomosis and not for resection. There is a need for a modified circular stapler with a larger open housing in order to safely resect the entire Barrett's lesion. It is intended that the upper purse string suture is placed orally and the lower suture aborally from the lesion. Using a stapler with an open houses, the mucosa to be resected can be pulled in the housing under visual control. The advantages of SAM versus endoscopic mucosa resection are the circular en bloc mucosectomy, enabling a higher probability of complete Barrett's esophagus eradication, the possibility for accurate microscopic evaluation of the lateral and deep resection margins, and a low probability of post-intervention stenosis. Moreover, stapler-assisted mucosectomy may be combined with laparoscopic anti-reflux surgery, thus treating not only the Barrett's esophagus, but also the underlying disease, gastroesophageal reflux.